Welcome to the Neuroveda podcast for complex health. We feature guests who dive into ancient and cutting edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as about nature, culture, and politics. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health in Seattle, Washington. And I'm so very excited. We actually have two guests today. So, our first guest is also coming to you from Neuroveda Health. Her name is Dr. Brianna Cardenas, and she's a physician assistant. She's a certified athletic trainer and the founder of Healed and Empowered, an organization that specializes in optimizing health among those living with chronic illness. She has recently joined the team at Neuroveda Health, where she brings 13 years of healthcare experience. She's also a patient living with EDS, Ehlers-Danlos syndrome, an invisible condition that can be hard to diagnose and often discounted by healthcare providers as a result. Brianna's lived experience as a patient informs her work as a healthcare provider to others. I also need to mention she's a whiz with fascial counter strain. So if you've heard of that therapy, we're going to talk a little bit about that today. And the way that we're going to structure our podcast today is we're going to talk with Dr. Cardenas first, hear her story, talk a little bit about the background of CSF, cerebrospinal fluid leaks. And then we're going to have Dr. Andrew Maxwell come on. He's a board certified pediatric cardiologist and pediatrician. And so I'll read his bio when he gets on and starts, and we'll roll from there. So, Brianna, welcome. We're so happy to have you.
Thanks for having me. I'm so happy to be here.
Yay, we are too. Okay, so tell us your story because you actually have a really good, you've like a superhero origin story.
Well, thank you. Yeah, I definitely did not expect that to be the case years ago. Gosh, the story can be long. I'll try to do the abridged version. But I am somebody who about 11, 12 years ago started having just kind of weird headaches, not feeling well on a regular basis. I had just graduated PA school. I was working in pain management at the time and working really hard, right? Like doing the insurance based care, seeing 35 patients a day, working 5 days a week after having just finished PA school, where it's just like brutal, like basically, they used to say taking a sip out of a fire hose. So, just it's a lot of information, it's a lot of strain on your body, so I just figured like, "Oh, I'm just fatigued," taking time to recover from just the gauntlet that is getting medical education, and a lot of that too and my internal like, "Oh, no big deal, like, I'm just tired, maybe this is just what getting older feels like, maybe this is just stress," I think was a lot of, like, the internalized ableism of, like, "Suck it up, just go to work, everybody feels a little headachy sometimes. Everybody feels a little under the weather sometimes. Like, just deal with it." But over time, those symptoms got worse. It progressed to like waking up nauseous every day. It progressed to feeling brain foggy on a regular basis, not being able to function without caffeine, and just feeling kind of like a zombie every day. And I had gone in this process to multiple colleagues just to try and get some help. And the answers for like my symptoms from some of my colleagues were everything from like, maybe you're just like overweight and a Latina. Like, sometimes these things just happen. And sometimes you guys are just, a little anxious and a little expressive with how you feel. I heard the term Hispanic panic in the ER once as it referred to me. So yeah, I know I see your face, Jillian, and I feel like everyone listening is probably like mouth agape as explaining these things. But over over the course of this time, I was just like, okay, well, maybe I am just like dramatic, right? Maybe like everybody loses their vision the second half of the day. Maybe everybody like feels dizzy when they stand up. Maybe everybody just has like a racing heart rate all the time. And it finally got to the point where I started like collapsing at work on a regular basis. And by this time, I had multiple MRIs. They were all read as normal, multiple workups, head to toe, different specialists with really no answers. And because I had already had a diagnosis of EDS, I knew that I was going to probably have to like take my care into my own hands. So I started researching more about like what are the common headache co-occurring conditions or comorbidities that occur with this connective tissue disorder. And I found things like Chiari malformation and upper cervical instability and spinal fluid leaks. And so I knew I didn't have a Chiari on my imaging. And I narrowed it down to either upper cervical instability or spinal fluid leaks. And I literally self-prescribed myself like a hard cervical collar and said, okay, well, if this helps, it's the instability. If it doesn't, it's probably a spinal fluid. And the cervical collar helped a little bit, not enough to make a meaningful difference. And so I kind of like narrowed my own diagnosis down and then taught myself neuroradiology specifically for spinal fluid leak morphometrics, which are like the measurements we do to look for spinal fluid leaks. And I had every single one of them, despite my brain MRI being read repeatedly as normal. Went to the center where the author that wrote the paper that I found happened to work and showed up at their doorstep after collapsing at work one day and was like, help, I think I have spinal fluid leaks. And they were like, yeah, it really sounds like you do. And they did the imaging and they were like, yeah, you actually have 6 areas where you're probably leaking spinal fluid. We're going to do the procedure called a blood patch to help you, and you should feel better. So I did it in 2017 and, it helped, like, miraculously right away, all my symptoms gone, but it only lasted for a week, and I was like, "Oh, man," like, this close to having some relief, and then fast forward, it took about 3 years, back surgery, and 21 procedures in my spine to end up getting to the point where I was functional again on a regular basis and able to return to work. So, yeah, it was quite a harrowing tale. I feel like sorry, that was kind of a long, abridged version, but that's, I think, the best I can condense, like, a few years of mystery illness symptoms. So let's talk about the basics of CSF. So CSF stands for cerebrospinal fluid. It's the fluid that bathes and nourishes and cleans our brain and spinal cord and all the nerve roots that leave our spine and innervate all the things that our bodies do. All the nerves that touch everything from our tongue to our tailbone, right? So, and all the way down to our toes. So there's a membrane, actually there's 3 membranes that wrap the brain and spinal cord. They're called the meninges. One wraps the spinal cord, that's called the pia, and the brain. It's kind of like, the analogy I give is like if you had a scuba suit on your body, if your body's the cord and the brain, then the scuba suit that you wear is like the pia matter. That's the innermost layer. Then you have the arachnoid matter, which is like kind of if you had a looser bodysuit over that. And then you have water all around that suit. And then imagine if you put one more, like the old timey underwater suits with like the little keyhole for the mask around that, like almost like an astronaut suit, then that's your dura. And that outermost layer is supposed to be really tough, like leather, and it's supposed to hold all the spinal fluid in. And when we do procedures like epidurals, for example, we're supposed to inject outside of that and not puncture that membrane because when we puncture that membrane, the spinal fluid can come out and then it can affect lots of other things. So that membrane, like I said, is supposed to be really nice and tough, like the skin of a drum or like the top of a drum. In people who have Ehlers-Danlos syndrome or other connective tissue disorders, it's more like a Target shopping bag, like the nicer plastic ones, not the little flimsy ones like they used to be, not leather, right? So it gets the job done for most of us, but it is predisposed to having areas that kind of outpouch, like diverticulitis in your intestine, but like diverticular changes of the dura can occur. And then also those pouches can stretch out and eventually seep fluid, and if that goes on long enough, because there's such a tight interface with veins, arteries, and the lymphatics around the brain and the spinal cord, those all start to experience changes when there's pressure dysregulation of that spinal fluid. And then people can get really kind of transient things that come and go, different symptoms that affect really any nerve in the body, from the cranial nerves of our eyes to like the little tippy nerves down by our toes and hands. So we can really get these widespread nondescript symptoms when there's any type of spinal fluid pressure dysregulation. So it makes it really hard to kind of pin it down, and it makes it hard for patients to really describe with any consistency what's going on in their bodies. They just know they don't feel well.
When I first learned about the meninges, I remember learning that, dura is tough, means tough, like durable, and mater, the mater, the second name of pia mater, and dura mater means actually mother, comes from the root of mother. And so I remember learning about this outer meninges as the tough mother. And I remember thinking, yes, so protective and strong. And so when we have abnormalities, congenital or acquired, that's that layer that can thin. That's such a good description. Thank you.
Yeah, I'm so glad that you mentioned like the congenital and or acquired piece because At the time when I was going through this, the only kind of like risk factor in my brain at the time for myself was having the congenital connective tissue disorder. But the environmental component, the acquired component, the way that external factors or viral loads or other infectious burdens in our body affect that connective tissue, like literally wasn't even a consideration in my brain. Like this was 10 years ago. And like the research now is still in its infancy. So I feel like it just wasn't even something that the medical community was even talking about with at least any consistency at the time.
And I think that really speaks to why it was so hard for you to get diagnosed and why so many patients still continue to struggle to get diagnosed. It's really unfortunate that racism and classism and sexism still play such intense roles in why a clinician can't necessarily diagnose a patient. It's kind of like, well, maybe we'll just blame these other factors, which have nothing, obviously nothing to do with a connective tissue disorder. And I'm really sorry that happened to you. That's so offensive.
And it's so wild how, like, even the people who are, like, very well-meaning have these internalized narratives about different cultures and different, genders. Like, I remember the boss that I had at the beginning of these symptoms occurring. One of my symptoms was that I, like, suddenly started gaining weight. So, like, I gained 40 pounds out of nowhere, and now I know that it's because I was leaking spinal fluid and my brain was literally dropping down in my skull base, and it squished my pituitary gland, which is like your master hormone control gland. So it like really affected my metabolism. And I remember just kind of talking with my doctor, who I considered like a really close colleague at the time. And I still like keep in touch with him. I think he's a really nice guy. But I was like, yeah, I just like gained weight out of nowhere and I just, need to figure out what's happening. And he was like, oh, well, are you sure you're not pregnant? Because when pretty Latinas gain weight all of a sudden, that's usually what it is. And you can't say these things. But he was just really just trying to be like, "Oh, like, they're there, friends." They can't say those things, like, that's so problematic in so many ways.
Yeah, I mean, that would be a whole other podcast about ridiculous things that have been said to to patients about kind of what's going on when there's, like, a serious health concern.
Yeah, literally my brain was falling out of my head, and I was like, "Yeah, pretty sure I would know if I was pregnant, dude." Like, yeah, pretty sure.
And so as you're talking, like, let's talk a little bit more about that anatomy. So we've got these meninges that kind of protect and give that blood-brain barrier that's what is the blood-brain barrier. And there's an incredible amount of like signaling that happens, neurosignaling, immune signaling, endocrine signaling, and that is part of why the symptoms can be so wide-ranging, right?
Absolutely, and kind of dotted throughout these membranes are these things called the arachnoid granulations. They're in the head and in the spinal cord. I was just kind of reviewing some of my journals that I've read over the years on this, and the first paper that came out, let me find the year that this was published. This was like a 2022 paper that discusses that there are, in fact, human spinal granulations, like arachnoid granulations in the spine. And so if you read like the summary of the paper, it's like, it's been disputed whether or not these anatomical structures even exist. We're literally just to the point where we're like learning the anatomy, but the arachnoid granulations are part of what help regulate the CSF pressure, and they're the kind of like one-way release valves. So our brain makes CSF on a regular basis. We still don't know if there's other areas of the brain that make CSF. We, for the longest time, thought that an area of the brain called the choroid plexus was like solely responsible for making more CSF every day. I'd usually make it the most of it at nighttime around 2, 3 in the morning when you're sleeping. That'll be important for later. But we usually just make a continuous supply and it's got to go somewhere, right? So we have these like one way outlet valves kind of all through that membrane around our brain and our spinal cord. And they just dump that fluid into the veins. So they're very intimately connected with the veins around the head, the lymphatics of the head. We've recently learned about a system called the glymphatic system, which is kind of like the sewer of the brain that dumps then into like the lymphatics of our neck. It has a really strong interface with like the metabolic waste load in the brain, the immunologic response that occurs in the setting of like neuroinflammation. So yeah, there's like a significant and robust interplay between like all of the veins and arteries of the spine, all of the nerves of the spine and how they affect all of the other organs, all of the nerves of your face, like the cranial nerves that help you blink and smell and taste and move your eyes and your tongue and swallow and all of those things.
And so, what happens? Can you talk a little bit about the connection between the central nervous system and kind of the rest of the body in terms of like venous congestion or like vascular flow, or then vascular flow into the central nervous system or the cerebral circulation?
Absolutely. I kind of think about it because, like, I'm sure listeners are like, wait, like, slow down. It's just a lot of, technical jargon, a lot of information. But the way I think of it is like a very fancy plumbing system with the lymphatics serving as the drain in this analogy, the CSF that's like floating around in our head and our spinal cord as like the water in the sink, and the like faucet and where the water comes from as like the production of new fluid, for example. When we talk about like the metabolic processes that occur in a healthy, normal living being in the nervous system or in the response to inflammatory syndromes that our bodies come into effect with, whether it's like air pollution or chronic stress or like a foodborne illness or mold exposure, like any of these things that come into our bodies, those signals have to go up into the brain. And then ultimately, like they're really not supposed to get into this like plumbing network. That's what a healthy, functioning blood brain barrier is supposed to be. It's supposed to kind of keep that stuff out. Or a healthy dura, that tough mother is supposed to be like, nope, nothing gets in here. My brain and my spinal cord are precious. Like, no mold, no viruses, no bacteria get in here. However, sometimes in the presence of chronic stress, chronic disease, chronic inflammatory load, that dura mater gets a little worn down and stuff can get in there. Similar to leaky gut, we can get leaky brain, stuff can get in there. And now we're getting dirty stuff in that sink water and it starts overflowing and it outpaces the ability of those little arachnoid granulations or arachnoid villi, which are like, again, the drain outlet area to compensate. And so we can rapidly get to a place where that system is overpressurized, the sink's going to overflow imminently, and the drain ends up getting clogged. And then sometimes think of it like your pipe can start leaking later down. So, like, you can actually have an overload of these arachnoid villi. And because every single one of your spinal nerves has a set of those arachnoid villi, they can just start draining and draining and draining into the nerve root areas, the sheaths around the nerve roots, the sheaths around your cranial nerves, in your nose, in your throat, in any other area where like nerves exit the brain or spinal cord. So we can very quickly get this like overload scenario in which the system is like imminently going to decompensate. And then we start to have patients who don't feel well, don't feel well, don't feel well, but they're compensating, they're dragging through their day, they're getting through it. And then something happens. They get COVID, they live in a moldy house, they break up with a spouse and it's, some traumatic event and they have just like total nervous system dysregulation, whatever the case may be. And the system can't compensate anymore. It's like the straw that breaks the camel's back. And then all of a sudden people go from, I don't feel good, but I'm getting by, to like, no, things really wrong. I can't function. I can't word find. I'm not able to show up for my kids. I can't go to work. Like something is wrong. Help me. And then they go to get help from medical providers and they're like, I think you're just stressed, hon. Get a massage. Sometimes COVID just wipes us out. Maybe you need to go to therapy. And then, like, the imaging we have doesn't show these arachnoid villi. Like, we don't have the technology yet to image this small in living humans. So then people go a long time until they come to places like Neuroveda and get the help they need.
Well, we love that you've joined us. And so, can you talk a little bit about the positional component of CSF leaks? Because I think that's something that's a little bit unique in terms of headaches, is like, yeah, is that positional component.
Yeah, absolutely. The positional component is like really, I think, one of our biggest helpers when it comes to being medical detectives and like kind of trying to figure out what's going on with the patient. Kind of like, I don't know if people listening remember like those rain sticks where there's like a tube with like sand or like little beans or something in there. And if you tip it down to the bottom, like all the beans fall to the bottom. And if you flatten it out, like all the beans kind of go back to the other side. It's kind of like that with fluid pressure, right? Like we're like effectively think of it as like a tube with a big ball on top of it, right? Like a lollipop almost, right? Like if our spinal cord is the stem and our head is the candy part, right? But it's full of water. It's full of the spinal fluid. It's not water, but it's, full of spinal fluid. And when we stand up, everything goes down to the stem and we're supposed to have functional pumps that kind of induce a cranial rhythm or a cranial CSF flow. That's like how craniosacral therapy and some other like healing energetic modalities and body works work is they can sense that natural rhythm, kind of like how we have a natural heartbeat rhythm, we have a natural spinal fluid flow rhythm because if it just didn't have a pump and it just sat there, we like would just pool our fluid at the bottom. Like it's a functioning pump, kind of like how a fountain is where it's like continuous. There's a pump that like lets the fluid come back up to the head and then go down to the spinal nerves and then come back up and so forth. But if we have overpressurization, if we're up on our feet all day, if we're sitting all day hunched over with our head in front of us like a little croissant instead of like an upright human being like we're supposed to be. I know everyone at home listening is like, "Oh, I better sit up straight." But all of that can dysregulate the pump, and so, if we are in a chronic high overpressure scenario and that outflow obstruction is there, like our drain is a little clogged from all the things we talked about earlier, when you go to lay down, the headache gets worse, and all the water goes up back into the lollipop area and starts to create the sensation in our head. There's pressure there. Brains don't like being under compressive stress. So it starts to let us know, hey, you got to get up, you got to sit up, you got to start sleeping with a wedge pillow, you got to start sleeping with 2 or 3 pillows. I'm going to wake you up in the night gasping for air because I don't like this, right? So brain is smart and it will do a lot to protect us and you'll start getting kind of interesting signals from your body that like lying flat is not something that your body wants because it really doesn't want all that pressure on it.
And so, isn't there also like a component that if you have a leak, that you actually can't be upright because now your brain is sitting on your spinal cord? So, when does that part happen?
Right. So that part can happen if you look at literature from 15 years ago. It can only happen if a trauma occurs and that membrane tears, right? Like from a bad epidural that punctures into the dura. It's called a wet tap or a spinal tap. And some procedures do that on purpose, like spinal taps do that on purpose and make a hole, which makes a leak, especially in people with connective tissue disorders. That membrane sits along our spine, the whole entire central canal of the spinal cord. And if you have herniated discs, if you have arthritis in your back, if you have little bone spurs, that tough mother or that dura mater, even though it's supposed to be thick and tough, it's not a match for a bone spur. And so you can have a bone spur like literally just wear a hole in it. Like if you had a sharp part of your jeans and you kept rubbing against your leather couch, like it's gonna tear a hole in your couch at some point, right? But like if you had your keys on your pocket or something like that. So you can get a leak from some type of trauma. You can get a leak from like a whiplash injury or some kind of car accident or like getting hit in sports or like falling off your bike. But in folks who have this chronic high pressure scenario or chronically backed up drain scenario, we kind of have all these areas that are kind of weak and vulnerable to just kind of finally letting loose, right? Like a pressure relief valve. And so Dr. Maxwell's paper that he wrote talks about how like high CSF pressure and the lack of ability for that compensation that's naturally supposed to occur to keep up with the overpressure can literally end up creating like holes in this dura mater, the dura membrane, in order to protect the brain. And then if that hole is low enough, actually, if that hole's anywhere, but the thinking is that like the lower they are, the more positional the components would be. Like if you had a water bottle and you made a hole at the bottom versus if you made a hole 2 inches down, you're going to lose more fluid, is the thought, if the holes are way down at the bottom, right? So folks, when this finally occurs, will experience things like the inability to be upright for a long time. If it's a really slow, kind of one drop at a time seepage of fluid into like a vein or something like that, um, it will appear as a very slow kind of my boss that helped me at the end of all this, he referred to it as my wilting time, like the time of day where I would just kind of start slowing down and I'd need some more coffee and I wouldn't feel good. And it was always the second half of the day where I'd start to drag and then would take a little nap and like put my legs up the wall and that kind of stuff at lunchtime and be like, okay, I've got a couple more hours. But people will start to notice that being upright is a driver of their symptoms. They'll complain of things like their head feels too heavy. They'll have symptoms of things that represent the nerves at the base of the brain or the structures at the base of the brain being compressed. Like the pituitary gland sits under the brain. So having the brain drop down and squish it will create hormonal things. Like I didn't have a period for a year. And at the time I was 28. So it's like, it's not supposed to happen. And then all of the cranial nerves are at the base of the brain. So everything from vision changes to difficulty swallowing to trapezius muscle tightness and spasming can occur as the brain literally drops down and squishes those nerves between the hard skull base and the brain itself. Yeah, gravity ends up not being our friend after things after the system decompensates.
Before Dr. Maxwell gets on, let's try and talk about two of the treatments we might see or might want. So, can you talk a little bit about blood patches or embolization, and can you talk a little bit about fascial counterstrain?
Yeah, yeah. So, in the literature, you'll find blood patches, embolizations, and surgeries as, like the peer-reviewed evidence-based guidelines for treatment of these procedures. An epidural blood patch is basically like taking some of your blood, or some of the patient's blood, and injecting it back into the epidural space, kind of like fix a flat. You just basically go in and you hope that the blood makes a little scab over the hole. Wherever the hole's at. Sometimes we don't even know where it's at, and we call it a blind patch. We're just like, hope this helps. And for a lot of people, it does. And so it takes about 6 weeks for that scab to form. The patch is just kind of that first part, and then you need your body to kind of heal and use that blood and its clotting factors to make a nice little seal and hopefully seal that leak. If you have something like a CSF venous fistula, where now, like, instead of the arachnoid granulations slowly dumping fluid into the vein, kind of a little tiny bit at a time, you've basically now got this free communicating channel into your venous network of your spine. That's not going to show up on an MRI very well without special imaging because like the fluid's not just leaking freely, it's like just directly dumping into a vein. We can do I can't do that. I shouldn't say wait. Places can do procedures called embolizations where they go in and kind of like block and interrupt that flow with something like fibrin glue, and it like basically builds a little dam so that the spinal fluid stays in the dura instead of going into the spinal veins. Or people can have surgery. And so I had surgery for one of my 6 areas that was a slow leak, and that helped a little bit. But it didn't help all the way, right? I still needed 17, 18 procedures after I had back surgery. And so something that's not evidence-based as a, approved treatment yet, but the thing that helped me never need a blood patch again, get my health back, get my stamina back, and feel like, oh my gosh, like I might be able to like return to being a functional, vibrant, healthy person was a manual therapy called fascial counterstrain. And I learned about it in the Maxwell Masterminds group. That's where Jillian and I met, was at the conference hosted by this incredible group of human beings. And because I had had so many blood patches, I had developed scar tissue in my spine where my spinal cord tethered to my dura. It's called a tethered cord. And I was ready to go have surgery to go get it fixed, and I consulted the group and I was like, "What can I do for a tethered cord? Smarter people than me, like, how do I get help for this?" And I saw a post from Kelly Barnes, who is, like, one of my favorite humans, and, she's in Portland, and she was like, "I can treat that with my hands." And I was like, "Excuse me? Like, what?" Yeah, I know, I was, like, definitely eyebrow raised, but she was like, "Yeah, let me chat with you on the phone. Before you cut your spine open again, like, why don't you just come visit me in Portland? Give me a couple hours, like, let's see what I can do." And I went and visited her, and all of the stiffness from all of the scar tissue from the 21 procedures plus surgery that I had had in my spine that made it feel like if I was turned the wrong way, I was gonna tear something, or, things were just gonna be really bad news in my nervous system. She addressed that with the gentlest manual therapy that I've ever felt. And I felt like she was, like, reversing disease and scar tissue in my body. It was incredible, and I got up off the table because my main request was I'd love to be able to bend over and tie my shoes again without feeling like my back is gonna snap or something bad's gonna, like, rip or tear. I feel like I'm gonna, like, tear scar tissue open or something. My legs would go numb, and I'd feel like I couldn't feel my bladder or from the waist down anymore every time I bend over. But I was like, "I would just love to tie my shoes." And I got off of her table and I bent down and I tied my shoes with no pain.
Wow.
And I was like, "What did you just do to me? Like, this was life-changing." And she was like, "It's fascial counterstrain. You should take a training. We've got an intro class in a couple of weeks. I can teach you how to do what I just did, and then you can help other people." And so I went to the training a couple of weeks later, and continued to get treatment myself with a local practitioner. And my entire mindset and I think my framework of what my life could look like started to shift because I went from thinking like, gosh, I would love if I could just spend most of my time upright again. I would love if I could just work again. I would love if I could, get my pain down to like a 4 or 5 out of 10 every day again. And then just blowing past those milestones into like, I can't wait till I set a PR in rock climbing. I can't wait till I can go run and dance around at a festival. I can't wait till I can travel internationally again. Like just completely blew wide open like the potential for what my life could look like. And so I was just all in. And then now it's just over 3 years later, I've taken all of the curriculum. I'm planning to certify as like one of the fewer than 100 practitioners who are certified fascial counter trainers across the country. And I think the gals told me as I left the office in Seattle on Monday that I'm 90% booked for these appointments in our Seattle office through May. And it's March 28th right now. So it is, yeah, an absolute godsend. And since I had my first counter strain treatment, I have never needed a blood patch again. So I went from getting 3 procedures a year, which was acceptable to me. I was like, yeah, it's 6 weeks recovery every time. Yeah, I don't feel good in between, but I can function to like, I haven't had a blood patch in over 3 years. And I'm like unrecognizable compared to who I was even 3 years ago.
What an incredible story. What is fascial counterstrain doing? I mean, so just to for listeners at home, what it feels like to me is Dr. Cardenas gently puts like a finger or a couple fingers like on your body, either on your head or your neck or your body, and it's like very gentle. And then she puts her other hand in some other gentle place, and it's like a very gentle touch, like you would do for like your grandma when you're like, oh, we're at a restaurant and oh, honey, your food is here. Like that level of like gentleness. And so talk to us. Dr. Maxwell should be joining in just a few minutes here, but talk to us just about like what is it doing and how does it mean you don't need a blood pad?
Yeah, I know. That's the question because the whole spinal fluid leak community, like when I was like, hey, everybody, I got my life back, they were like, how the hell is manual therapy
Yeah.
fixing the leak? Like, what? But fascial counterstrain, the paper on it is open access. So for those of you that like love to read research and that kind of stuff, the paper is open access on counterstrain.com. It's written by Brian Tuckey and some other colleagues from across the globe who are like leaders in their respective fields in fascia, lymphatics, pain science and autonomic nervous system and inflammation science. And the counterstrain paper basically mapped out the process of what counterstrain has been doing. So that kitchen sink analogy that I gave, think of the drain and everything being blocked as like those blocked lymphatics. The fascia in this analogy would be like the roots of a tree in your yard that are growing down and crushing the main line to the sewer or the septic tank. So fascia runs everywhere, all through our body. It's made of collagen and various other connective tissue fibers, and it is alive. In school, they taught us that fascia was like this inert membrane that didn't do anything, which made no sense to me in school. Hi, Dr. Maxwell. We're talking about fascia. And basically, what fascial counterstrain is doing is it's taking this disorganized and constricted fascia that's kind of crushing that sewer pipe or this lymphatic system and putting it back into a position where the tissue can normalize its tissue tension and drain the lymphatic pump so that all of the inflammation that's just stuck in the tissues can leave that area and that tissue can actually heal and normalize. So when we do that for structures that are like surrounding the dura, for example, or we drain the epidural venous plexus, or we work on the phylum and the dura itself, we normalize the biotensegrity and reduce the adhesions and the restrictions on that tissue that make it dysfunctional. And then over time, that tissue heals healthier, stronger, and with better function.
Fantastic. Fantastic segue. Hello, Dr. Maxwell. Hello. How are you?
For you guys.
Doing absolutely. I mean, it's pretty perfect because it's actually a pretty perfect segue to the spiky, leaky component. So, what we've been talking about is CSF leaks overall, and Brianna's story about kind of her history, and then journey into fascial counterstrain as needing. I think Brianna was at 17 proceed or 21.
I had 21 epidural blood patches, fibrin glue patches, PRP patches, and back surgery. So, yeah, I had a lot of procedures and then stopped needing them after my very first counter strain session. So,
Oh,
It was really a fantastic change. And part of the big mystery during this whole thing was, why do I keep leaking? Why do I keep blowing patches? What is happening? And fast forward to 2023, where we found out that we had been living in a moldy home, like such a moldy home that the contractor said, you need to knock this house down and rebuild it. You can't even successfully remediate it because it's so bad. And finding out that that was very likely the thing that kept putting me in the overpressure, and the thing that kept my connective tissue weak, and the thing that prevented me from healing, because my poor mast cells were like, help, you're sick with mold. We're not going to let our defenses down. And I kept leaking. So I think that living in mold really exacerbated the severity of my leaks, the chronicity of my leaks, and made it so that I kept needing repeated interventions.
Well, I'm sorry I missed your history there to hear the whole story, but sounds like you were spiking, but it sounds like all the leaks were intraspinal and not necessarily intracranial.
That's correct. Yes, I had 6 perineural cysts at my thoracolumbar junction, and one of them was a CSF venous fistula. So after 3 blood patches that were incredible, but not durable in their duration of relief, I had a double hemilaminectomy, foraminotomy with synthetic dural graft and clipping of the CSF venous fistula. Sorry, you see, I'm having to like pull that whole procedure out of my brain. I had to dig way back in the file cabinet to describe it accurately. But then after that, I was still leaking. And so after back surgery, I was like, gosh, what do I have to do? And so I just kept getting patch after patch after patch after patch after patch, to the point where I ended up getting a tethered cord and adhesive arachnoiditis because I had gotten blood and glue injected into my spine. A
Is
total of 21 percutaneous procedures.
iatrogenic tethered cord, you think?
Yes, exactly, plus mold illness. So it was just really like this perfect storm of just chronic mast cell activation, chronic tissue degradation. Reading your paper was reading my autobiography, basically. It's like looking at the way that you so beautifully detailed this pathway and this chronic cycle that people find themselves in. And seeing it on paper, seeing it in a chart was just so affirming for me as somebody who fortunately was on the other end of it, but didn't have words to describe what had happened to me.
So you're one of the patients that actually like the chart.
I loved the chart.
When
Yeah,
I present that at conferences, people's eyes glaze over, or like, really, you're going to go through that entire pathway?
it all matters. It's a complex pathway. If it weren't complex, people wouldn't wait years and years to get a diagnosis.
So at the point where you recognized that spiking of your CSF pressure was part of this, were you able to either get that measured or get people to convince that maybe that was part of it?
I was not. I had an opening pressure done with the spinal tap when I first got diagnosed, and I was in the low normal range at the time because I was already leaking through that CSF venous fistula. And then when I didn't get better, the person at the institution where I had originally had my surgery and my procedures dismissed me as a patient because he said it's impossible for you to be leaking again. I fixed your fistula. Cysts don't leak, is what he told me. So those other cysts are not, a problem for you. And he just told me to go on my merry way. And I am so, so thankful every day that I have a robust network of amazing colleagues, because one of my colleagues, Dr. Tina Wang, knew that it was not okay that I was continuing to have symptoms. She called one of her friends from her PMNR residency, who she knew was a little bit of a cowboy with new procedures. And she said, hey, will you blood patch my friend and colleague, and will you try it with PRP? And he said, sure. And he ended up doing my PRP patches, or platelet rich plasma patches, targeted at those cysts on an outpatient basis after the person who originally helped me refused to continue seeing me. And I was able to get better with targeted transforaminal PRP patching at the remaining cyst levels.
Wow. Yeah, and of course, the idea with the increased intracranial pressure is, as you said, if you're actively leaking, your pressure is going to be low on an LP. But even if you weren't leaking, maybe post patch, and you're still having the symptoms, if you were to go in and get measured, it's very common that it would still be normal, because these are intermittent spikes and they probably are occurring when you're deeply asleep, because you're retaining CO2 then and having the blood vessels blossom within your skull, allowing lots of blood to fill the skull and displace CSF, raise the pressure at that point. So unless we're actually doing lumbar punctures on patients when they're deeply asleep and retaining CO2, we're not going to be capturing this high pressure. It has to sort of be inferred. So, how do you believe the counter strain was effective?
I believe it was effective for a couple of reasons. So, we had explained to the audience the anatomy of the arachnoid granulations and arachnoid villi in both the head and the spine at the various nerve roots. Those arachnoid granulations are present at every single cranial and spinal nerve root level. And so, because they were kind of chronically overpressurizing my epidural venous plexus and preventing the pressure normalization from occurring, because the main role for the folks listening of those arachnoid granulations is to help regulate some of that spinal fluid pressure and kind of be physiologic, like pressure relief valves. If you have chronic obstruction and chronic backflow there, and then now you're getting basically like varicose veins of the spine, for lack of a better way to describe it, and that pressure can't go anywhere, then you're going to chronically be backing that drain up and kind of creating this pressure scenario internally. And so the fascial counterstrain alleviates fascial restrictions and normalizes the biotensegrity to turn the lymphatic pump back on and drain some of that excess interstitial inflammatory stasis, or like the stuck stuff in the tissue for people that are like, what did she just say? So alleviating the inflammatory burden locally at that tissue and improving the lymphatic and venous outflow of the adjacent tissues, I believe helped normalize the functioning of those arachnoid villi at that CSF venous junction at the affected levels of my spine. And it also dramatically reduced the number of adhesions I had along my dura, because there are direct dural points in fascial counterstrain. So all of the restricted movement that I had and kind of like almost the micro tears that I felt were occurring when I would just like bend over or turn my head a certain way along my whole dural system loosened and weren't so restrictive. So the tissue tension, it's like if you had a shirt with too much starch on it, like if you stretch it, it might tear. Versus if you like softened it up and let it move freely the way it's supposed to, then it's going to function a lot better. So I felt like it normalized both the venous return, the ability for the tissue to heal, and also the actual tension on the tissues themselves.
Like you're making a pretty good argument that fascial counterstrain is one of the first places that patients should turn if they think they have a spiky, leaky situation.
In my opinion, it is. I mean, we don't have evidence-based literature to support that yet, but the science supports it. So the counterstrain paper is open access on counterstrain.com. We know that it reduces physiologically and mechanically the sympathetic nervous system tone. So it reduces sympathetic activation. It reduces the interstitial inflammatory stasis. So we're removing interleukins and other tissue degrading enzymes and inflammatory, catalysts for more disease and more dysfunction to occur out of that tissue. So we're like making the tissue environment more healthy. And then over time, my anatomy teacher in college used to say structure fits function. So when we remove inflammation from a structure, or at least reduce it and manage it, it's kind of like managing our mast cells and seeing an improvement in all these other things. We basically are allowing that tissue to function in a more proper and closer to its physiologic norm so that the body can actually start to heal. So I would love to shout from the rooftops. And I'm, trust me, in these Facebook groups and on my social media being like, try counter strain before you let people stick needles in your back. Because, it doesn't hurt to try it while you're waiting 8 months to see a specialist anyway.
Maybe you've already addressed this with the audience, but how easy is it to find a fascial counterstrain person? And do all fascial counterstrain folks know what to do? Is it you need particularly skilled for a problem like this?
No, that's a great question. I'm glad you asked it. So counterstrain.com/clinics has a directory of practitioners. We're all over the country. We're most densely populated in the Pacific Northwest. And so there's a lot of us out here. There's a lot of us kind of in the East Coast as well. And the training of practitioners has dramatically expanded in recent years. Kelly Barnes is actually the person who introduced me to fascial counterstrain. And I told the story a little bit earlier about how she changed my life. And it's pretty easy to find a practitioner. As a heads up, most practitioners don't take insurance because it's not considered like a billable procedure for most practitioners. And then on each person's directory listing, there is a list of the courses that that individual has taken in the counterstrain curriculum. Right now, there's 16 courses in the curriculum. I've taken all of them, and the more advanced courses like the central sensitization 1 and 2 are the courses that teach the deeper epidural, or excuse me, the deeper spinal, venous, and arterial work. So if somebody is going to go see a practitioner, in a perfect world, they would see someone who has had the majority, if not all, of the curriculum under their belt, and patients can easily identify that on each person's directory listing.
And then is it typical that a patient needs to return for therapy again and again? Or is there a eventual healing that occurs where therapy is no longer required, or maybe just at a maintenance level?
I believe that with consistent treatment at the beginning, in conjunction with treatment of whatever the underlying pathology is for this patient, that the gradual lessening of treatment is indicated. So when I first started, I was going every 2 weeks because I had mold illness, later got long COVID, and had all of these procedures. I also have EDS. I also have MCAS. I also had upper cervical instability. So I had a lot of things going on. So I went every 2 weeks for a year, as much as I could do. And now we're 3 years in, and I get a treatment maybe every 2 months. And then I like trade with my colleagues as we're studying for certification. We just like co-treat each other when we get the opportunity to. But I went from being completely bedbound, using a walker, having brain fog, not being able to remember my phone number some days, and being lucky if I could walk a block to the coffee shop for the whole day. That was like, all of my spoons for the day used, to like this week I commuted 2 hours to Seattle, worked all day, went to the airport, got on a plane, came to California. Now I'm working all week to see counter strain patients down here. And then I'll go back up and go home and then work again next week. So like my capacity has dramatically improved. So I guess to answer your question, it's I think a gradual improvement can be expected, but the sicker and more complex a person is, the harder it's going to be to get to that place. And that can be facilitated by working with practitioners like yourself, Dr. Ehrlich, and a lot of our Maxwell Masterminds colleagues to manage pharmacologically or medically some of the other comorbidities that are making the tissue angry in the first place.
Are there procedures or maneuvers that can be taught to the patient themselves that they can perform some of these things themselves without the need for a therapist?
Not in fascial counterstrain, but there is a technique called the Perrin technique that a patient recently told me about. And it's a manual lymphatic drainage, and it's a combination of seeing a Perrin certified practitioner as well as a modality and sequence of self lymphatic drainage that gets taught to the patient. And it's actually being studied to see if it can help with ME/CFS symptoms because so many of their patients get better. So there are similar kind of approaches to helping that lymphatic pump, but there aren't any like patient centric where like patients can self treat curriculum at this point in time in fascial counterstrain.
Can I ask you about your Ehlers-Danlos?
Absolutely.
Did your signs and symptoms predate your exposure to mold?
Yes, I had EDS diagnosed when I was 20 in my athletic training rotation. After I had woken up from back surgery or excuse me, from knee surgery at age 18 with terrible back pain, walked around like that for 2.5 years, being told I was depressed and Hispanic, and that was the reason my back hurt. And then finally had a colleague and mentor at the time, my preceptor, say, can I look at you because you shouldn't be limping at age 20 like this? And found out that my SI joint was dislocated and had been dislocated during the transfer off of the surgical table and stayed dislocated for 2 years. So he put it back in place for me and then did a physical exam and was like, yeah, your body shouldn't bend like this, my dear. I think you have EDS. And then later got that diagnosis confirmed with my family practitioner who was willing to go out on a limb and help me get a diagnosis, even though he had never diagnosed a patient with it before.
In retrospect, was there any indication that maybe mast cell was involved in your pathology early on as well?
Absolutely. And because I am a person who my mast cells manifest primarily in my nervous system and not cutaneously, like I don't have a lot of skin manifestations or rashes or things like that. I didn't clock myself as a mast cell patient, even once I started learning about it, until I was like, oh, that anxiety and ADHD and executive dysfunction and brain fog is all mast cell related. Yeah, definitely didn't clock that earlier, but yes, in retrospect, I can see how that played a very big role.
Would you endorse the idea that maybe originally it was in some environmental exposure, maybe not the mold that you were experiencing later, but some environmental exposure that activated mast cells, and the mast cells then kind of turned you into an Ehlers-Danlos patient.
Absolutely endorse that idea, actually. I'm listening to Brain Maker by David Perlmutter right now, and he talks about like just how being born cesarean, for example, predisposes you to like an altered gut microbiome, increased sympathetic nervous system activation. So I was a C-section baby who was an emergency C-section. I grew up in a family with like a lot of ACEs, and like that'll be for a whole other podcast sometime. So chronically stressed as a child, chronically like in a state of emotional and physical danger on a regular basis. Lived next door to the freeway when they were constructing the 210 freeway. We were the last house that was like allowed to stay. And then they knocked down all the houses next to us, so exposed to a ton of construction debris. They built the freeway as I was growing up, and then we lived next door to the 210 freeway. And I grew up in Southern California in the Inland Empire, which we are the national champions for worst air quality several years in a row. And most recently, we have discovered that I have heavy metal toxicity, very likely from the discount braces that my parents got for me that I could taste all the time. So I'm pretty sure I had heavy metal exposure in addition to all of those environmental and nervous system and neurological, just to my sympathetic nervous system. So yeah, absolutely. I think that my environment took me from somebody who potentially could have been still on the hypermobile spectrum at some point, but like full blown hypermobile EDS presentation, I think was certainly hastened by my environment.
I'm going to take this moment to kind of interject because I do want to read your bio, Dr. Maxwell, because I just want people to know a little bit more about you. I did a short introduction in the beginning, and then we can talk a little bit about spiky leaky. And thank you, Dr. Cardenas, for being honest and accessible with your story. It can be hard to be forthright with personal information. It makes you vulnerable. And so I really appreciate you sharing for the benefit of our patients. Thank you.
My pleasure. If it helps somebody, like that's, we're all dealing with different stressors. And I think the more that we hide it and feel shame around it, the more we suffer in silence and makes it harder to heal when we can't be open with it. So thank you for saying that.
I think I'm going to refer several of my patients for fascial counterstrain and see how they improve. Definitely the less you do intervention wise for these patients, usually the better. So that sounds like a really, really good place to start.
Absolutely. I'll text you after the podcast some of the practitioners in your area who I'd recommend.
Okay, thank you.
So Dr. Andrew Maxwell is a board-certified pediatric cardiologist and pediatrician. He received his medical degree from Johns Hopkins Medical School and his residency in pediatrics at the University of California, San Francisco, followed by clinical and research fellowships in pediatric cardiology at Lucile, Salter, Packard, and Stanford Hospitals and Children's Hospital of Philadelphia. His research interests include study of endothelial control of vasomotor tone, nitric oxide, sports cardiology, dysautonomia, hypermobility syndromes, and mast cell activation syndromes and their relationships to environmental toxins. So this is like perfect, unfortunately perfect. For his research, he received an American Heart Association Award for Research in Molecular Biology and was an American College of Cardiology Young Investigator Award finalist. He's published many articles and book chapters on these subjects, including the article that we're talking about today with spiky leaky syndromes. And for his clinical work, he's been voted by his peers as a top doctor in Northern California annually since 2017. So welcome to the show.
Thank you.
So talk to us a little bit about the spiky leaky. Why is spiky leaky such a big deal?
Oh gosh, because I think it's much more common than any of us realize. In fact, if we look at the POTS patients that I see and look at the frequency of spiky leaky within the POTS patients is pretty high. And the order of 15% are showing early spiky leaky, not necessarily the full blown spiky leaky, but showing cranial cervical instability and evidence that really points to spikes in their CSF. Not necessarily leaks, but spikes, and probably more along the lines of 5% of my POTS patients. And I don't know whether that's unique to my population, because I think that, my particular patients are very often environmentally exposed patients, and they go down this pathway of developing a mast cell activation, followed by a hypermobility, followed by the dysautonomia and POTS physiology sequence of events. And so CCI, cranial cervical instability, is high frequency in these patients. And once you have cranial cervical instability, then you're kind of on the road to spiking and leaking. So it seems to be pretty high frequency in my patient population. And the question is whether I'm not unique in that, and that everyone else is seeing the very same population that I'm seeing.
Yes, absolutely. Absolutely. And so talk to us then about, like, we've talked a little bit about the anatomy and about drainage and flow, but talk to us about like what is spiky and what is, we kind of have, we've kind of focused a little bit more on what is leaky, but talk to us a little bit about how the spiky happens.
I mean, the core theory in these patients is this tied in, tied out phenomenon that occurs, blood flow first being restrictively flowing into the skull case, to our brain during the day, and then the opposite happening at night, where excessive amount of blood flow flows into the skull case, which is a fixed volume, flows, in and around our brain at night. And so it's this exaggerated, tied in, tied out phenomenon that occurs diurnally. And so the spike occurs when we're asleep. And it all has to do with carbon dioxide levels. So during the daytime, these patients tend to, have a POTS-like physiology, meaning their parasympathetic function's not working well, blood volume sitting low, so they're losing what's called the flow into their heart, their preload, which means they lose their stroke volume, which means they become dependent on heart rate more than stroke volume. And what happens with that is the sympathetic nervous system recognizes that the parasympathetic's not doing its job. So the sympathetic goes into overdrive, and that's all through adrenaline. And so when it's in overdrive, it causes fast heart rate, palpitations, racing heart at baseline, palpitations, dizziness upon standing, orthostatic type symptoms, but worse, because what happens is you hyperventilate as part of this. You breathe too fast and you blow down your CO2. So if you were to measure blood carbon dioxide levels, and that's to be differentiated from bicarbonate levels, like on a basic metabolic panel blood test, that's not the same thing. You would have to do a blood gas if you were going to measure this. Or the way I measure it is with end-tidal CO2 during an exercise test. So if you see that the carbon dioxide level in the blood is low during the day, what happens is blood vessels to the brain constrict with low carbon dioxide levels. That's just basic physiology, that one of the most tightly tied determinants of blood flow to the brain is your blood carbon dioxide level. So if you're hyperventilating, your blood carbon dioxide level is low, you vasoconstrict, which means even less blood flow to your brain than what's caused by the POTS phenomenon, the loss of cardiac output. And so you're brain fogged because of it. But the big picture there is through the day, you have less blood volume, which means CSF has to fill the space. So you're actually kind of on the high side of volume with your CSF during the day. The CSF is produced by the places that in the brain that produce the CSF, and it fills that void that the blood is lacking. And it kind of sets you up for this tied out phenomenon, the tied out being the blood volume is out. Then you go to sleep at night. And for all the various reasons that a person with hypermobility loses their airway, and that could be the jaw falling backwards, the TMJ being loose and falling backwards. That could be floppy airway tissue. And that can be C1 slipping in a different position that actually compresses the airway from the back. So there's a lot of different reasons why patients lose their airway. And you can add on to that extra lymphatic tissue and lymph nodes and tonsillar tissue that might be inflamed from having part of mast cell activation. But you lose your airway at night. And it may not be full on obstructive sleep apnea. So you can go get a sleep study, and it may not be that abnormal with what's called high AHI, apnea hypopnea index. It may be more subtle than that. And that's what we call upper airway resistance syndrome. So that's where the ventilation of your lungs and the gases that are in your lungs is just reduced, but it's not completely obstructed. And so that reduction in ventilation elevates your carbon dioxide in your lungs, and that's of course norm is across the tissue into the bloodstream as well. And so your CO2 in your blood raises, and it may go from normal is 40 millimeters of mercury of CO2 in the blood. And during the daytime, you may be hyperventilating where it's down in 30s. And I've got some patients even in the 20s. That's how badly they're hyperventilating. They go to bed at night, and during a sleep study, it's measured that their carbon dioxide raises into the 50s. 55 or so. And where a sleep doctor may say that's not all that bad going from 40 to 50. Well, if you're going from 27 to 50, that's a big deal. That's a huge change in the blood flow to the head in a very short amount of time. And so that blood flow is equal to blood volume. So big change from low blood volume to high blood volume in a few hours' time. And that can't be managed by the arachnoid granules filtering out that CSF and draining it away, particularly if you've got jugular venous compression, the normal venous route of drainage of CSF. If it's compressed in the neck by all these other things that are compressing the airway, it can't filter through. So you get a spike in the CSF pressure, and that has to find an out. And it's going to find the weakest place. And in some patients, that may be in these, the Tarlov cysts and all in the spinal column. But for a lot of patients, they have a strong enough uh, dura within the spinal column, and it finds other places to leak. And the first place that we find is it tends to what we call Windkessel into the sheaths around the cranial nerves. So Windkessel is a typical term cardiologists use when they talk about where blood capacitance goes, when it has to be moved from one normal place, like blood vessels, to reduce pressure, it Windkessels into extra vessels that are otherwise not used. In this case, this is CSF Windkesseling into the sheaths around the cranial nerves. So it's a capacitance. It's a place to store CSF that when the pressure goes away, it can just slip right back into the normal places around the brain. But if that Windkesseling is overwhelmed, if the capacitance is overwhelmed, it leaks out the end of the cranial nerves. And what we find is that the first place that it does is it leaks across the cribriform plate through the olfactory nerve into the sinus tissue. And that sinus tissue then becomes boggy and it becomes overwhelmed because it's supposed to be drained away by the nasal lymphatics, the sinus lymphatics. But those lymphatics are also compressed at the neck. The same thing that's compressing the jugular vein, the same thing that's compressing the airway is compressing the lymphatics. So they're overwhelmed, and the CSF tends to weep into the sinuses themselves. And then when a patient wakes up and sits up, they gush fluid out their nose and sometimes down the back of their throat. Patients claiming coming out of their ears. So that's the phenomenon in the big picture. And there's a lot of components to that that explain other phenomena. That's kind of it in a nutshell.
A very compressed, a very pressurized nutshell.
That's my 90-minute talk.
Amazing.
It'll make a great Instagram reel, Dr. Maxwell. You did a great job.
Well, I just got to learn to dance.
I know we just need to coordinate our Zoom squares to point or something. We'll be rocking and rolling.
So any
So
questions from that?
I know. Well, so what do we? So I'm curious about how we see that. Like, if that's happening for a patient, if there's a patient sitting at home right now going, "Is that what's happening to me?" Number one, kind of where, like, how can you find out if that's happening? And then on the flip side, kind of what can we do about it?
Right. I mean, both those are very big unanswered questions right now. And that's what I spend a lot of my time working with. So some of the people who have recognized this, some of the neurosurgeons who said, yes, I believe this to be happening all along. I just never, had it put all together in one big comprehensive explanation. And some of the ENT docs as well, who say, yeah, this is what I'm seeing in my patients. Now, and some radiologists are kind of getting together and saying, how can we best evaluate this? Like I said, a lot of these things that you would want to be able to test are only testable when a patient is deeply asleep and retaining CO2. The pressure in their CSF, the movement of CSF across the cribriform plate or other places, they're only happening when you're retaining CO2. So it's not the ideal time to even be in an MRI machine trying to detect some of these things we're trying to detect. So we're doing our best to come up with methods to look. DMX, digital motion X-ray seems to be one of the things we're doing. Cone beam CT scans, simply because their ease of availability and the inexpense of a cone beam CT scan. You can often get a nice cone beam CT scan done in an orthodontist's office at my request, a simple little order, and they're willing to do that. Part of the cone beam CT scan, if you're going to do that, requires the application of a package that looks at the airway cross section and determines what is acceptable cross sectional area and what is not, red versus green. So that's an important part of the cone beam CT scan. But there's other imaging. CT angiovenogram is becoming core to this, where you're not just looking at the arteries, but you're looking at the veins, particularly the internal jugular vein. But of course, that's all positional, because are you going to see what you need to see in a person who's aligned their conscious versus what their airway and everything is like when they're actually deeply asleep? So a lot of things still need to be worked out, and then what to do about it. Boy, that's a big, big question. There's the slide I have that first shows the complex pathway that's complex enough by itself, but then it's overlaid with particular strategies. It starts at the top, talking about removal from the environmental source that's causing the mast cell activation, the suppression of mast cell activation, strengthening of craniocervical unstable parts. And is that best by prolotherapy? Is it best by physical therapy? Is it best by surgical intervention? Myofunctional therapy helps with the position of the tongue to prevent obstruction that way. So that's been a big part of what we're trying to do. The list goes on and on. What if we interrupted the CSF production with something like Diamox, slowing down CSF production? In some patients, we're actually using Lasix, which is kind of counterintuitive to a POTS patient. You're putting them on Lasix, very low dose, and it's to slow down CSF production the way Diamox does, but not everybody can tolerate Diamox. And the idea there is if you can stop the spike, you stop the leak, right? So a lot of these patients, they're only leaking when they hit a certain pop-off pressure, and at that pop-off pressure, then it forces the CSF across these tissues. There's a pop-off pressure there. So that wouldn't work for cases like Brianna, who have no pop-off pressure. They're leaking at no pressure at all. So these you got to identify the patients that already have an active anatomical leak, and they're leaking at no pressure at all, because something like that is only going to make them worse. So and a lot of times that's what happens with these patients. They popped off to the point where they've created their own anatomic leak, and now it's something that actually needs intervention.
Wow. We're going to pause for a quick second and say goodbye to Dr. Cardenas. Thank you so much for joining us.
Thank you so much for having me. Thank you, Dr. Maxwell, for the work that you've done and the paper that you've created. I think it's going to help so many people beyond what you can possibly even imagine. It's already helped so many of my patients, and I'm just so grateful for the work that you and Dr. Ehrlich and our colleagues do. So thank you so much. Have a great day, everybody.
You too.
Thanks also goes to Deborah Wardley, who's the co-author on the paper and who has helped with every aspect of, the whole theory. And she is instrumental simply because she is one of these patients. And so
Oh,
there's
wow.
nothing like the lived experience to really drive you to try to understand it. And, fortunately, she's a physician and a, medical researcher. And so is in a position to understand what she was going through and some family members.
Wow. Yeah, fantastic. Thank you. Thank you. Yeah, and I think that lived patient experience is, what we just saw with Brianna and her experience. And so it's incredibly informative. And if it's you, you got to get real innovative. You got to figure things out. So, yeah. So with spiky leaky, what about CPAP, or what about like interventions that actually just increase oxygenation, and is it possible to kind of rebalance blood pH with that overnight?
You mentioned CPAP. You're talking about what can you do to make sure the airway is not lost at night. And every patient is different there. And some of the evaluations kind of help pick that apart, because if it's C1 slipping forward and compressing the airway from the rear, yeah, CPAP may overcome that, but is there a better way? And so all these patients that I'm caring for usually get first an airway evaluation, LEAP study and cone beam CT and all that, but then they're evaluated by an airway specialist. And a lot of times that entails getting myofunctional therapy involved. The Oftentimes, what happens is that it's found that the tongue is just kind of too big for the mouth, and sometimes it's because the jaw didn't grow forward far enough, and that needs to be rectified. But the first step is getting the tongue in the right position. So myofunctional therapy is helpful. But a lot of times, some sort of expansion of the mouth is necessary. And that could begin with a lateral palatal expansion. And that may have some merit, but usually the airway specialist will say you cannot laterally expand your way out of an airway problem. It usually needs to be a forward expansion. So talking about, orthodontia that it increases mouth size rather than decreases it, or more aggressive approaches like what are called maxillomandibular advancement of the jaw. And so some of these patients have solved their airway problem that way. That's not necessarily for everybody. Look at the where the obstruction's occurring. We realize no, it's this one is not the tongue being too far back. This is going to need to be addressed by another approach to open up, say, the internal jugular vein and that entire, what's called the neurovascular bundle there. And so approaches with that have been looked at. Everything from what's called a stylohyoid ligament release to other surgeries that remove some tissues that are not essential that then allow the internal jugular vein to be more widely patent. So CPAP itself is always a good first step. And usually it then requires you going to BiPAP, because if you think about what CPAP does, yes, it stents open the airway, but it also pushes air into the lungs. So if you're trying to evacuate CO2, it actually kind of uh,
Yeah,
uh,
the
it
backward.
raises your CO2 and doesn't solve the problem. So BiPAP would be the more appropriate approach. And so it's, the idea behind BiPAP is the pressure disappears when you're exhaling, and it promotes the exhaling of air, but stents open the airway otherwise. The trouble is, though, is in reality, BiPAP is not well tolerated for the long term. Usually you're waking up with the instrument, the apparatus at your feet or, otherwise off your face. And particularly for young people, which most of my patients are, it's not a long-term solution. And they don't tolerate it very much for very long, but it might be at least a test of concept. Like if you were to get away with BiPAP, uh, uh, and for a long enough time, would your headaches resolve? These high pressure and low pressure headaches resolve with successful BiPAP. And the other problem with the apparatus is it often is placed in such a way that it actually constricts the airway itself. The band that holds it in place might constrict the jugular vein more, or otherwise push the jaw back. And so there are logistical complications with such things as BiPAP and CPAP. So you want to move on to something more durable as quickly as possible when you are doing it.
Got it. Got it. And what are some of the other causes for the spiky besides kind of that reduced or that rise of CO2 at night, like the decreased breathing? Are there other sources for the spiky component?
Well, I mean, the theory that we have, the CO2 seems to be an important part, but some of that we're still working out. We need to go back and look at studies of our patients that have had sleep studies and how many didn't have all that much change in their CO2 from low to high at night and still had spiky, leaky phenomenon. Like, is it overstated the importance of the CO2 retention? So that still needs to be done. And a lot of, the whole paper is a theory, meaning it still needs to be proven. And there's many, many components within it that needs to be proven. But we felt that the phenomenon was important enough and prevalent enough that we needed to publish what was still yet a theory so that it could be torn apart and picked apart. And we're welcoming that. Have other people who say, either believers take it a step further or non-believers say, no, this is not, this component here doesn't make sense. And I'll show you why. And we're open to that. And so that one question, how important is the retention of CO2 and the development of spiky leaky part of it? Is it all compression of the internal jugular vein? Could you have any amount of CO2 day or night, and you're going to have spiky leaky because you're compressing your internal jugular vein. And that's the entirety of it is compression of internal jugular vein and not the CO2. Possibly that's the case. So
And that would be, I mean, can you talk a little bit about styloids and elongated styloids and Eagle syndrome?
yes, yes. Well, we call a lot of this pseudo Eagle syndrome. And the true Eagle syndrome is where your styloid bone, which are these little bones that protrude kind of under where under your skull, not far from your ear, these almost like saber tooth shaped bones that then they hold the styloid ligament, or this stylohyoid ligament, rather. They hold that in place, and that ligament goes down to your hyoid bone, down lower in your neck. And what we find is that it's not that the bone is elongated, which is true Eagle syndrome, but the bone is rather calcified and looks like bone on radiology, but it's calcified from chronic inflammation, from the lateral tubercles, these little wings that come off the sides of the C1 that are chronically rubbing on the styloid ligament that calcifies it. And the poor neurovascular bundle is in between. And that neurovascular bundle includes the internal jugular vein, some artery as well, and the vagus nerve. In fact, it's not just the vagus nerve. It's cranial nerve 10 is the vagus nerve. It's 9, 10, 11, and 12. And they're all cross-talking with each other in what's called the pharyngeal plexus. And cranial nerve 9 gets injured, and that's the source of a lot of neuralgias that these patients have. And it's really, really one of the clearer aspects of when to suspect cranial cervical instability and when to suspect the early onset of spiky leaky is having symptoms that are consistent with injury to cranial nerves 9, 10, 11, and 12. So 9, the glossopharyngeal, when it's injured, it causes pain to the base of the tongue, but it causes a lot of inner ear symptoms, vertigo, hyperacusis, like everything sounds louder than it should, phonophobia. Regardless of whether it sounds loud or not, people don't like the sounds. Like they don't like being in a crowded room, like a restaurant where there's ambient sounds. It just drives them crazy. So there's vertigo, hyperacusis, phonophobia, middle ear pain, tinnitus, and it may be pulsatile tinnitus. It may be unilateral or bilateral tinnitus. Sometimes it may be one ear only, and sometimes it's both. So those middle ear symptoms are classic. Sometimes the feeling of a globus, a mass in the back of the throat, where it feels difficult swallowing. You feel like you have a mass in the back of the throat, but anyone who looks says, no, no, there's no mass there. It's fine. So those are the glossopharyngeal symptoms. So that's 9. 10 is the vagus nerve. So this is where a lot of the dysautonomia, I believe, comes from. Dysautonomia, including the creation of a POTS phenomenon, but also GI motility is a big part of it. Slow GI motility and nausea, bloating, early satiety, pain with eating, things like that. So that's cranial nerve 10. And then it may be bigger than that too. It may be chronically racing heart that's independent of the POTS phenomenon, that it partly feeds the SA node. And so you got to get this inappropriate sinus tachycardia, is what we call that. And inappropriate sweating or inability to sweat. So everything that you could think of that the parasympathetic nervous system controls is now dysfunctional. So that's 10. 11 is the spinal accessory nerve, and a big part of that is feeding into the trapezius and the back muscles. And so these patients don't just have a uh, coat hanger pain that a POTS patient would have, but they have a knottiness, really intense knottiness to their trapezius muscles that a masseuse or physical therapist can't, just massage out. So a lot of these patients are asking for muscle relaxants and all because of that. And then finally, cranial nerve 12, which reflects up and becomes sort of the occipital nerve. And so a lot of occipital headaches that patients are seeking occipital nerve blocks for. And the real source is at this one place where C1 is slipping forward and pressing against the stylohyoid ligament. That becomes calcified. It looks like a long styloid bone. It's given the diagnosis of Eagle syndrome. But if you look at the radiology carefully, you'll kind of notice a little knuckle in the bone along the way. And you say, no, that's the end of the real bone. And the rest is calcified ligament. And the funny
It's
thing
kind
is,
of like a bone spur almost on the tip there.
yeah, I mean, I have to, bone spurs I think of as, an extra spur coming off a normal bone. I guess if you say the spur is the continuation of the styloid, then yeah. And, I've talked to radiologists about this who will comment on, there's a, st- uh, a really long styloid bone in this young patient. Or they'll even say calcification of the hyaloid ligament. They recognize that it's not the styloid bone. And I'll say, isn't that surprising to you that a 17-year-old has calcified styloid ligament? And they'll often say, "Oh yeah, but it's pretty common actually." Really? Well, what would make that common? Well, yeah, I mean, these are usually patients that have been in a motor vehicle accident or something where they've had a major injury to that location. Like, okay, so it's common to have it, but usually it's involved with a major injury to that location. And if you don't have that history, then why is this major injury occurring in a patient who's never had a motor vehicle accident or something major? So
Yeah,
again,
yeah.
it's probably a lot more common than we realize that C1 is slipping forward and injuring these structures and causing this.
So with that nerve plexus in there, is there any role for these patients for stellate ganglion block?
Well, the stellate ganglion block is more to block the effects of the sympathetic overdrive. And so, if a patient has a big component of sympathetic overdrive, is either part of the POTS phenomenon or part of, the injury there to the vagus nerve, then it will help that. But I think that's kind of a down the road. If you look at my chart, where you're trying to interact at a level above CCI or right at CCI, that stellate ganglion block is way, way down at the sympathetic overdrive part, which is kind of in the middle of the chart. So it's not that low down. And so the idea there is if you're blocking the sympathetic overdrive, you're blocking the tendency to hyperventilate. And so if you're blocking the tendency to hyperventilate, you're not having the loss of the blood flow during the day. And so that would then reduce the spike and leak phenomenon for that standpoint. But that's kind of at the same strategy level of, giving a patient a beta blocker. You can do either stellate ganglion block or you can give them alpha and beta blockers and do the same thing. I'm not discounting. I've had a great experience of patients getting stellate ganglion blocks for anyone who has kind of like a POTS phenomenon with sympathetic overdrive, not just the spiky leaky patients.
Yeah, fascinating. I feel like we could talk a lot longer on this, but I don't want to take up too much of your time. And I'm really grateful for you joining us. And I just want to reiterate like what a gift it is to have both of you on the show today, kind of balancing out the whole story. I think this is a huge story. I think that it is one of those things that we're seeing more and more in patients, just like you're saying, that really isn't being identified at this point. And so certainly a lot more understanding, evaluation, treatment, assessment, everything to come. Thank you for being here. Any last thoughts you want to share with the audience?
I mean, I'm just very, very thankful to have the platform to talk about this. I could go on and on all day about all the different particulars, and maybe there'll be a podcast just specifically on what I call the olfactory nerve cuff junction. And it's pathology. So there's so many different parts of the bigger theory that we could spend hours on.
Absolutely, absolutely. And I think we should just mention here at the end of the show that you're really the guy who kind of termed the pentad. There was published on the triad, but you're really the pentad, like the namer of the pentad. So we should have that out there for our audience to know like the magnitude of this guest today. So thank you for all your hard work. We're really grateful. Yeah.
All right. Thank you for having me.
Thank you. And we love that you've joined us today, all of you here in the audience, to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Nerveda podcast for complex health, and we'll see you next time.